Welcome to this video on Dial-A-Pan S at QE Gateshead, our outcomes and advice for Dial-A-Pan S users. In this session, we're joined by special guests, consultant obstetrician and gynecologist Jill Sturt, and matron for acute midwifery services Claire Cameron. Together, they share their experiences of introducing and using Dial-A-Pan S, the results of their service evaluation comparing Dial-A-Pan S with Prostin, and their practical advice for other maternity teams considering or already using the cervical ripening method. So let's begin.
So hi everyone, my name's Jill. I am a consultant obstetrician at the Queen Elizabeth Hospital, as Shelley's already told you. So today my colleague Claire and I are here to talk to you about our experience of Dial-A-Pan as a mechanical method of induction of labour in our unit. So yeah, next slide please, Shelley. Thank you. So a bit of background, we are quite a small district general hospital in the northeast of England with a birth rate of about 1,800 to 2,000 births per year. We started using Dial-A-Pan about 5 years ago in December 2020. So that was obviously right in the middle of the COVID pandemic. We initially started offering Dial-A-Pan to our low-risk patients. So essentially they were low-risk prime rips for post-dates induction, which I'm sure most of you know are quite a rarity these days. This meant that the number of women who were eligible for Dial-A-Pan was obviously quite low. And then on top of that, we also gave these women a choice of either having Dial-A-Pan or hormonal induction of labour, which further lowered the numbers of people who were actually taking us up on a Dial-A-Pan. We did an audit of our use of Dial-A-Pan over a 6-month period, so from December 2020 to April 2021. The audit, unfortunately, was only 16 patients, but despite this, the results were positive for its use, and we used that to make a case for us to be able to offer Dial-A-Pan to all of our patients, unless it was obviously contraindicated. So a year later, finally, in December 2021, we were able to offer it to all patients unless contraindicated. And 4 years on, we are still using it in our unit as our sole method of mechanical induction of labour. Next slide, please. So if we could go back in time to sort of December 2020, 5 years ago, when we were starting our journey with Dial-A-Pan, what would we change about the setup of our service? So number one, I would say just go all in, offer it to all eligible patients from the very start. I think our mistake was to take a slow, gradual, gentle approach to making change, and it didn't work. It allowed people to stick to what they knew best and what they felt was comfortable. So people don't like change, and to be able to make a successful change, I think you need to be able to see the benefits quickly. And our low uptake of Dial-A-Pan meant staff weren't witnessing the successes of Dial-A-Pan regularly enough to feel comfortable promoting it as a method of induction of labour. And they therefore reverted to what felt comfortable, which was using Prostin gel. Number two, I would make it your first line method of induction of labour. So unless there's a clinical reason not to have Dial-A-Pan, all patients should have it, and they shouldn't really be given a choice of mechanical versus hormonal. I mean, that might be a controversial statement, but I do think particularly in the small unit like ours, it's essential to gain experience and evidence in a timely fashion, which is obviously quite difficult to achieve when you've got low numbers of uptake. Obviously, there'll be patients where hormonal induction as a first line method of induction is appropriate for whatever reason that might be. But I think a standard policy of mechanical induction with Dial-A-Pan as first line method of induction would be my advice when you're starting off. And then the final thing, which I think Claire might touch on a bit later, would be to ensure that the Dial-A-Pan is actually removed sort of around 12 hours. We found women who'd had it in for longer. I think when we first started, we were leaving it in sometimes for 24 hours, and we found that there was some regression in their cervical dilatation. Next slide. So training and education. This, in my mind, I think is the most important and key to successfully implementing Dial-A-Pan use in your units. I would suggest training core members of staff in all staff groups that are involved in antenatal and postpartum care of our women. So you basically need core sort of labour ward midwives, PAU or MAU, antenatal clinics, obstetricians and community midwives, and give these core members of staff a title, for example, Dial-A-Pan champions. So their purpose is really to be an accessible contact point, with accessible being the key word there. They need to be visible on the shop floor, out in the community, in clinic, alongside other members of the team and also patients, to make them accessible and approachable. They're there to strengthen the lines of communication and support staff, so people are generally more comfortable and more likely to ask a member of their team that they know well and I know is approachable. So putting on drop-in or ad hoc hands-on training sessions, education sessions, makes them much more accessible to staff that are busy shift workers. And I think these Dial-A-Pan champions are there to sustain the enthusiasm, which we didn't really have at the beginning of our journey. And once they're confident with its use, others will see this and kind of follow suit. Dial-A-Pan, so an insertion of it is obviously a new skill, so people need to be trained with hands-on experience. And AG Health have got an excellent training model that you can purchase from them. And the reps are also very helpful at coming out and delivering hands-on training with their models. We've certainly had quite a few training sessions within our units, and the staff have found them very useful. I think, as you all know, with a technical skill as well, so doing it on a model is a completely different experience to doing it on a patient, and it takes practice to gain confidence and competence. And this is where the Dial-A-Pan champions would come into practice again. So being there alongside the staff members on the shop floor to give moral support and troubleshoot, particularly being there when staff are putting their first couple of Dial-A-Pan into real life patients. And as I said in my last slides, you've got to have high turnover of patients coming through to insert Dial-A-Pan into. If you have that, you're going to achieve your competence and confidence in staff much more quickly. There's two ways of inserting Dial-A-Pan. So you can either do it digitally or with a speculum, and everyone's got their preference. And again, people need time to find and perfect their preferred technique. I know a lot of people who started off thinking, actually, I prefer speculum, and they switched to digital and the other way around. And then finally, don't forget the community midwives. They're like key people to educate and train as part of the setup of your service. Claire and I have been out to our community midwives on a number of occasions to educate and train them. I think they're really imperative in counselling women on the benefits of Dial-A-Pan, because basically they're the ones that build up a rapport with them during the patient's journey, their antenatal period. And sometimes, quite rarely now, but sometimes there are the odd patient where actually they're the only health professional that they see until they hit the labour ward. So when they come in and see me or one of the midwives, they've only met us once, and they're not really going to listen to us. They're going to be listening to that midwife that they've been through that antenatal journey with. So make sure you speak to your community midwives and involve them in all the training and education when you set up your service. Next slide, please. Top tips. So these are my top tips, split into sort of three areas. The first one is timing of insertion. So think about that carefully. What works best for your labour ward and workload. Think about when would be a good time to be doing ARMs and work backwards from that. But you also obviously need to take into account the patients and what works well for them. So they're not going to thank you if you're going to start bringing them in at 2:00 in the morning to have their Dial-A-Pan removed and having their waters broken. So in our hospital, we bring ours in about 3-5 o'clock in the afternoon. By the time they've got settled into their induction room, had a CTG, had a presentation scan, all of that kind of stuff, by the time we get around to actually putting Dial-A-Pan into them, it's normally about 6 o'clock, 8 o'clock in the evening. So then they're coming back 12 hours later, which is obviously 6, 8 o'clock in the morning for removal and ARM, which works well, obviously, for them and for us. Next is place of insertion. I think that one of the main benefits of Dial-A-Pan is that it's less invasive. It's a much more natural induction process, and I try and advocate for that as much as possible. So following that through, I try to avoid bringing them down to a labour ward room, putting them in a lithotomy position, shining a spotlight on them at the bottom of the bed. That's all quite a very clinical, surgical environment. So instead, I try and keep them in our induction rooms. So in our induction rooms, we've got just normal hospital beds. I use a wedge to aid pelvic tilt. And my personal preference is to digitally insert the Dial-A-Pan. And I think that's just for two reasons. One is just that's my preference. I find it easier to do it that way. But also patients, there's quite a few of them are quite reluctant to have a speculum. So I think they prefer digital insertion. Having said that, those that have speculum are quite happy with that too. And then the final tip is about preparation. So obviously you've always got to be prepared. I take an assistant with me for two reasons. So one is to kind of advocate for the patient, help calm their nerves and look after them. And then second, to actually be a second pair of hands for me, because I use two sponge holders to insert it. So I've got one in my hand and then another one on the side that's preloaded. The assistant will pass to me and then they reload the other one. So the Dilapan comes individually wrapped. So each one is in its own single packet. So you need to open 4 or 5 packets to ensure you've got enough for each insertion. We all find them quite fiddly to open here. So, if you're in the middle of inserting one Dilapan and then the poor assistant can't open the next one, it's a bit awkward. So get them all open, ready to go before you actually start putting them in. Gel. This was one of the tips from the AG Health staff, actually, using lubricant. So aqua gel, dip the tip in the end of the gel, and I find it just makes them slip into the cervical canal much more easily. What else? Oh, finally, so gas and air. So there's the occasional patient that gets a little bit uncomfortable and benefits from a little bit of gas and air, not often. But I've learned from experience, just make sure you have that set up ready to go. There's nothing worse than mid-procedure having to abandon ship to go and find a mouthpiece, plug the tubing in for the gas. It looks a lot more professional, keeps the patients nice and calm. Yep, next slide, thank you. Language used, rods. That is my bugbear. I hate people calling them rods. And the number of patients comes to me say, I spoke to the doctor and they talked about these rods. I'm not really sure about that. Think about if you're the patient and the health professional told you they were going to put 4 or 5 rods into your cervix. Certainly for me, I've got this image in my head of someone shoving 5 metal rods the size of a drain pipe into my cervix. I'm not going to go for that. So I describe them as mini tampons. For a number of reasons. It's something that's already associated with being inserted into the genital area. It's something that people can relate to. And then also, Dilapan works like a tampon, so it's slow, gentle swelling process. Obviously, the tampon doesn't stretch the cervix open, but it's the same sort of idea. Other things, so birthday candles. Again, some people might think, oh my God, you're not going to set a light to me, are you? But they do actually, it's a very good description of them. They are very similar to little birthday candles. And then trying to use language like natural, explaining there's no drugs in it, no hormones involved. It's all very kind of positive language. Next slide, please. And then the counselling of the women, which is obviously important. I think it's kind of split into 2 main areas, with the first one being kind of the benefits of outpatient induction of labour. So talk to them about being at home and how this promotes early mobilisation, which obviously in turn helps with the onset of labour. The benefits of being at home with your own home comfort, so sleeping in your own bed, eating your own food, all kind of things like that. And then for women who've had children already with siblings, a lot of them like the outpatient option because it means that they're away from home for a shorter period of time. Another thing just to be aware of is to make the patients aware that you don't have to go home if you've got Dilapan. You can be an inpatient, still have it. There are a small number of patients who've obviously got huge anxiety about going home and they feel much safer being in a hospital environment. So just make sure that they're aware that Dilapan is still an option for them. And then in terms of counselling about the mechanical side of it, so they should experience minimal hyperstimulation. Obviously, hyperstimulation could potentially lead to fetal distress and a potential emergency section before they've even got into established labour. There shouldn't be any of those so-called horrible prostin pains. Certainly in our case, there should be fewer examinations because once the Dilapan's in, we don't examine you again for another 12 hours, compared to in our case where we use Prostin gel, so they're being examined every 6 hours. I think Claire's going to touch on this again in a bit, but my personal feeling is that the less examinations leads to a lower rate of sepsis in people having Dilapan compared to Prostin. Balancing the argument a little bit is making them aware that obviously the examination with Dilapan in most cases is probably a little bit more lengthy than if they're having Prostin inserted and slightly more uncomfortable. But as I've just said before, the benefit of that is that they're only being examined after 12 hours again. And I think that's it, isn't it, for me? Can I have the next slide? Yes, so I'm going to pass over to Claire now, who is going to tell you all about her wonderful service evaluation project that she did as part of her master's degree.
Yeah, thanks, Jill. So hi, everyone. As Jill and Michelle have said, I'm Claire. I'm matron for acute maternity services here at Gateshead. And I'm just going to give you a little overview of my service evaluation that I performed for my master's degree. And I'm going to be completely open and transparent here, and apologies to AG Health, but I did go, I want to be open and transparent. I did actually go into this project with almost a slight bias, as like Jill has sort of alluded to. We brought Dilapan in. It was a bit of a slow burn to start with, and I think a lot of it was down to staff attitudes. Anecdotally, staff felt it didn't really work that well, and as matron, I'm tasked with looking at our QI projects and cost savings and things, and I kind of went into it thinking, well, I'm going to kind of do a good piece of work here to show that it doesn't really work, and we'll move on to something different. I was quite surprised by my findings, I'll be completely honest, and it has completely changed my opinion of Dilapan. So next slide, please. So just to sort of recap a little bit of what Jill said and the background as to why we started using Dilapan in the first place, and I'm sure this will resonate with many other clinicians on the webinar today. Within our organisation, we began to report induction rates creeping up to like 43% and climbing. We were experiencing significant staffing and bed pressures, and because of this, specifically impacting on patient flow and bed blocking on the labour ward. Our maternity dashboards and quality dashboards were reporting regular delays to induction of labour, which now obviously is a red flag on the birth rate acuity, and this in turn resulted in increased patient complaints themed around induction and staff satisfaction as well, that the bed blocking and the numbers of inductions that were just getting stuck on labour ward. So in an attempt to address these issues, we decided to implement a mechanical method of induction and opted to use Dilapan, as Jill's alluded to. And we started using it for a couple of years, and then kind of realised that we hadn't really evaluated it properly, which timed perfectly, luckily, for my master's dissertation. So this was a single-centred service evaluation utilising quantitative data retrospectively collected from our maternity electronic database. We use Badgernet here in the whole of the North East region. Actually, we use Badgernet, so it was really easy for our digital teams to pull the data for me. I asked the team to pull data from women who were admitted for induction of labour between the 1st of January and the 30th of June 2023. So that represented a time frame of sort of up to 24 months post implementation of Dilapan, when it was sort of considered that it was embedded into practice, although, like I said, anecdotally, people were still not sure about it. So it was secondary data analysis that was adopted because it was readily available. During that time frame, 406 women underwent induction of labour. 71 were automatically excluded for various reasons, such as they were being induced for fetal loss, or they were already suitable for ARM when they came in on admission, or they were less than 34 weeks gestation. And during this time, again, sadly, but not surprisingly, only 41 women received Dilapan, and the rest of those women received Prostin. So this meant I wanted to review all of the 41 cases where Dilapan was used, and so opted for a comparable sample of 41 cases where Prostin were used. And to remove any bias, a random sampling method was used using a number generator to arrive at all the Prostin cases. And this number generator was used by our digital teams, and they forwarded me these 41 cases of the Prostin cases to review, so that it was completely randomly generated, removing any bias, so that I had a completely comparable 41 cases to compare to. Next slide, please. So this slide, again, I think Jill's already kind of alluded to. By this stage with the Dilapan, we were using it on majority of people. So you can see all the inclusion criteria. We didn't rule out many people, even with our high risk pregnancies. We were offering by this point Dilapan. So you can see the exclusion criteria there, which I've sort of mentioned: less than 34 weeks, fetal loss, or any contraindications. Next slide, please. So the baseline characteristics were comparable in both groups, which surprisingly both had 51% of women being nulliparous, which would kind of fit with a lot more primates requiring induction. So here are some of the major findings. So greater changes were seen to the Bishop score from the first examination, Bishop score, to the second examination in the Dilapan group. So therefore, those in the Dilapan cohort required less subsequent cervical ripening interventions. Even more significantly, 40 of the women in the Dilapan group experienced rupture of membranes, as opposed to only 36 in the Prostin group. And interestingly, more women in the Dilapan cohort did require IV oxytocin, yet more women in the Prostin group experienced uterine hyperstimulation. Both groups did have comparable numbers of non-reassuring CTG traces. Next slide, please. What also was particularly interesting was the finding that a higher vaginal birth rate was achieved in the Dilapan group. Although this did include a higher number of instrumental deliveries, overall more vaginal deliveries were achieved with Dilapan, and more caesareans were obviously performed in the Prostin group, and a high proportion of these were actually due to failed induction, which was a really interesting finding. Next slide, please. The induction to birth interval was longer in the Dilapan group, with a mean of 30 hours as opposed to 23 hours in the Prostin group, and more women failed to achieve a vaginal birth within 24 hours in the Dilapan group. However, on reflection, it could be argued this is an unfair comparison, because obviously, as we've discussed, the manufacturer's recommendations are that Dilapan remains in situ for 12 hours before removal, which automatically increases the cervical ripening time compared with Prostin. Furthermore, the Dilapan cohort appeared to have more deviations in protocol, as Jill has also mentioned, where we found that quite a lot of the women were having Dilapan left in longer than 12 hours, which is the recommended manufacturer and unit protocols. So it could be argued that such delays impacted these outcome measures, whereby leaving the rods in longer than the recommended time frame potentially paused or reversed the cervical ripening process, as what can actually happen is the cervix can rehydrate once the rods have become oversaturated, thus influencing the induction to birth interval and mode of delivery for reasons unrelated to this induction of labour method. And finally, it could also be argued that achieving a safe vaginal birth is a far superior outcome measure than timescales alone, with the success of induction of labour being the achievement of a vaginal birth without a defined time limit. And given the higher percentage of vaginal births that were achieved with the Dilapan group, and the additional finding of minimal uterine hyperstimulation, which is similarly observed in other research by Gupta et al., it could be argued that Dilapan was overall the safer and more effective induction of labour method. Next slide, please. In terms of adverse outcomes, minimal adverse maternal and neonatal outcomes were reported in either group, actually, although less in the Dilapan group. There was a higher rate of low APGAR scores noted with the Prostin group, but the Dilapan group did have more low arterial core pHs. But in both groups, this could be attributed to subjectivity and sampling bias, so I don't think that was a significant finding. What was the most significant finding in relation to the objectives of the service evaluation was around length of hospital stay, as Dilapan reduced the length of hospital stay by up to 12 hours, 16 minutes, especially when used in an outpatient setting. And what's even more interesting is that in this service evaluation, length of hospital stay was significantly reduced in both the inpatient and outpatient Dilapan cohorts. So basically, regardless of whether the woman went home once Dilapan was inserted or not, her length of stay was still less than those in the Prostin group. So the time period where the woman was at home may not be the only causative factor. It's probably a direct consequence of the higher vaginal birth rate in the Dilapan cohort, resulting in earlier postnatal discharge. But these findings are certainly interesting and will require further study. We haven't put the stats in this. Oh, sorry. Carry on back a second. No, that's fine. We haven't put the stats on the slide here in this presentation, but just also a quick mention that in induction of labour for attempted VBAC, 50% receiving Dilapan experienced an outpatient induction and 50% achieved a VBAC. Conversely, the one woman receiving Prostin who was going for a VBAC experienced a failed induction and actually opted to continue on her induction of labour journey, receiving subsequent cervical priming with Dilapan as well. So when analysing the data relating solely to VBAC, the results were similar to other studies that have been published nationally, with minimal uterine hyperstimulation and adverse outcomes and a comparable vaginal birth rate. And it could be suggested, therefore, that Dilapan is a safer option in women attempting VBAC than Prostin due to the associated risks of hyperstimulation. And these studies therefore support further studies, larger studies, that Dilapan for cervical ripening and VBAC provides a safer option when inducing this obstetrically high-risk group. Next slide, please. So in summary, this service evaluation supports similar studies that Dilapan is a safe and effective alternative to pharmacological methods and contributes to the growing body of evidence supporting outpatient induction of labour. This service evaluation found Dilapan to be an effective agent for cervical priming, mirroring findings in similar studies, whereby improvements to the cervical dilatation enabled more women to have subsequent rupture of membranes and a reduced need for additional priming agents than the prosting group. And there, that links to that discussion that Jill had earlier around the slightly more increased sepsis rates in the prosting group. And I think that's probably down to this improvement in the dilatation and the lack of need for lots of different vaginal examinations. Additionally, NHS England advocates the delivery of high quality, financially sustainable maternity services that improves outcomes without compromising standards. Therefore, a reduction of 12 hours in length of stay has a potential to significantly reduce costs per induction of labour. Furthermore, a caesarean section, we know, costs considerably more than a vaginal birth. The increased vaginal births achieved in the Dilapan cohort provides an argument that when utilised as an outpatient induction, it potentially offers important cost savings while still achieving safe, high-quality, effective care. The evidence of reduced hyperstimulation is significant when considering high-risk populations where fetal compromise is present. We know that induction of labour rates have increased for many reasons, but specifically due to the increased antenatal detection of growth-restricted babies. This is a direct consequence, as we know, of the National Saving Babies' Lives Care Bundle, which advocates earlier induction in these populations and also those that have reported recurrent reduced fetal movements. But these babies may be more compromised at the start of the induction of labour process and are less able to tolerate the stresses of labour. So arguably, the use of Dilapan would benefit this cohort, as the low risk of uterine hyperstimulation further reduces the risk of fetal distress in this already compromised cohort. So in conclusion, the study provided convincing evidence that mechanical induction of labour using Dilapan is a safe and effective alternative option. Furthermore, when used in an outpatient setting, it's not only safe and effective, but it supports patient choice and considerably reduces length of hospital stay, which could significantly impact on patient experience and cost efficiency savings. So I have to say, my final findings did surprise me, and I'm a complete convert for Dilapan. And as Jill said, we have continued to use it very successfully in our unit. Thank you.
Brilliant. So I understand there are plenty of questions in the chat now. So Tijal from Royal Free. So have we had any cases of missing rods? So again, trying to use dilators as best we can as opposed to rods. There have been a couple of cases of missing dilators. What's really nice about it is that they are detectable on ultrasound and MRI. So if you are ever unsure about where those dilators have gone, we do recommend potentially doing a speculum examination to just double check that there's nothing in sort of posterior fornix and things like that. And then if you still aren't able to detect, then you can do a bedside ultrasound. Most likely they've sort of fallen out in the toilet, so we do recommend to, when you're counselling your ladies and you're saying, you know, what to look out for whilst they've got their Dilapan in, obviously bleeding, pain, changes in movements, and then make sure that they let us know if they've noticed anything falling out in the toilet as well. Jill, did you have something to add there, or?
Yeah, I was just going to say, I don't think we've had any cases of missing Dilapan. A couple of things to add on top of that is, so as Claire mentioned, we use Badger, the electronic maternity note system. So there's a bit on there for induction of labour where you select the method. If you select mechanical, and then I think it says automatic dilators or something, you select that, and then it asks you how many rods you've put in. So you would then select that, so that then the person who's removing them 12 hours later, because hopefully it's not the same person, they know what was put in before. The other thing is, yes, they start off like birthday candles, but they swell up quite a bit, and they've got a different consistency when they've swollen up, and you tend to remove them. They're all removed in a clump. Yeah. So it's not like, I feel like one falls out and then another, like they all come out together. So I feel like it's quite, as you've said anyway, Shelley, very rare to have missing ones. They kind of stick, they just, I don't know how to describe them. They're just very sort of jelly-like and sticky. Yeah. So they all stick together, basically.
Yeah, we've had a couple of cases where like maybe we've inserted 5 and one's fallen out fairly quickly. You hadn't had a chance to do that, but I'm not aware that any that we've had, so we were then aware that there was only 4 left in, say. So we've certainly not had any instance reported where there's been missing, and that would have been an instant report. No, we very much make sure we account for all of the ones that are removed.
Perfect. Thank you so much, Jill and Claire. The next question I can see is from Natia about sort of timing of insertion, which I think, Jill, you've already sort of mentioned, but I don't. Would you mind sort of going through again, sort of time of insertion in your recommendations for that?
Yeah, so we, as I said, try and work backwards from when you think timing of ARM would work for you. So we tend to bring them in the morning, so 6, 8 o'clock in the morning. They come in just before everyone else, chaos breaks, sets off, and try and get all their Dilapan out about 7, 8 o'clock in the morning, and break the waters then. Obviously, you know what maternity's like, not everything fits to that schedule, but that's kind of the basic schedule for our induction of labour process. But we bring them in about 3, 5 o'clock in the afternoon, because you've got all of that workload to do beforehand, doing a CTG, talking to them, presentation scan, whatever you might do with your inductions. So all of that takes time. So although they come in at 3 o'clock, as I said before, we probably don't actually put them in till sort of 6, 7 o'clock in the evening.
Perfect. Thank you so much. And I've got a question from Amy. Do you offer outpatient induction to all patients who have induction with Dilapan, or does this depend on their individual reasons for induction of labour?
So yeah, it's kind of patient choice. As I said before, I mean, I think the main benefit is you can have outpatient induction of labour, but that doesn't appeal to everyone. Some people want to stay in hospital, they're very anxious. We do have people who we aren't, what would you say, kind of an exclusion criteria.
Yeah.
So if they don't speak English, we don't want them going home and then not being able to communicate with us if there's a problem, or they've not got transport to get back in immediately if anything happens. I'm trying to think what else is on that. I think if they've got reduced fetal movements,
we do a risk assessment, don't we, on all of them? I mean, we try and promote outpatient induction, but I think that there's always you get some patients that just maybe have a few risk factors that you just think they're not risk factors for having Dilapan, but you're just thinking, I'm not sure I want this woman to go home, and you discuss it with them. But if the woman really, really strongly feels, we would never keep them in. But there were. I think it's about that risk assessment on Clark in them that they're completely safe to have the Dilapan. They're all patients, like Jill said, we should be using it as a first line because it's much less risky anyway. But I think there's still those ones that you maybe want to just keep an eye on from a fetal monitoring perspective, or that should have other poor obstetric history, or that there's always individual. I think it's an individualized case-by-case basis, really.
Perfect. Lovely. Thank you so much. And I think the next question is probably directed towards you, Claire, as well. Again, from Natia. Have you experienced much delay in ARM? Does the cervix then change / revert, and the ARM not performed? And then a follow-on question from that. How many have had to have an additional mechanism due to it not working?
Yeah, now I've got to try and get me cogs going back to remember my masters now. There wasn't the delays to ARM were it would have been down to workload reasons, not because of the cervix. So, like I said, in the 41 cases with the Dilapan that I looked at, 40 of them were able to, they either spontaneously ruptured their membranes or they were able to be ARM. So that was just such a stark finding. So when we're doing it not outside of my masters, we're on the labour ward, the delays to the ARM are down to workload on labour ward, not because they're not able to be ARM. The majority are favourable for ARM. There are always the odd case that doesn't work, of course there is, but we don't tend to find that the delays are more and more around workload on the labour ward. Does the cervix then change revert? I think, well, that's the risk that we found previously is if you leave them, it's the rods being in, I think, is the problem. You need to get those rods out because, like I said, that the evidence is from the research I did as part of my masters was that those they reach a saturation point, the Dilapan rods, don't they? And then the cervix then can go through its own physiological process of rehydrating. So then you've not got that change in the cervix then. So I think that the the trick is remove the rods at your 12 hours, even if you're not able to proceed workload wise with the ARM, because then we haven't really found an issue. When they're ARMable, then they're able to be ARM'd once the workload allows. And how many have to have additional mechanism due to it not working? On my master's process, there was very few that needed subsequent. I think there was minimal. I think there was just one, wasn't there, that needed the additional priming mechanisms. But I would have to look at our current data. I haven't researched again since June 23, so I'd need to go back and look. But there's not that many, anecdotally, I'd say, Jill. There's not that many that have to go on to have an additional priming. It's usually the other way, that we've given Prostin and then we go on to give Dilapan. But I mean, Jill, what your feelings on that? How many have?
I don't have an exact figure, but it's not that many.
No, there was minimal, obviously, in my actual findings from my research, but yeah, we don't have that many that go on needing additional Prostin.
And just to add on to that, one part of our training is that once you've removed your Dilapan, we do recommend doing a lovely big membrane sweep with consent, obviously, just to ensure that you are continuing that stimulation and continuing to make sure that that cervix remains nice and open as well. We have anecdotally heard of women that have waited a very long time, so sort of 60 hours for their ARM due to, delays, and their cervix remained unchanged. Now, I can't promise that for every woman that has a Dilapan and has it removed, but we do know that it is a potential as well. So yeah, we do, as we follow with what Claire says, remove them, get that membrane sweep done, and then try and get that ARM done at sort of your earliest opportunity.
Yeah, and that's exactly what we find.
Perfect, lovely. Next question. What is evidence that the Bishop score regressed if Dilapan is left in for more than 12 hours? So there is a study which I can share up with you, Aparna, afterwards, which essentially shows sort of the Dilapan in for 12 hours compared to the Dilapan in for 24 hours. And it shows a better Bishop score gained within that 12 hours versus within 24 hours. And the reason being for that really is because we know how the Dilapan expands over time, and it pretty much reaches its maximum expansion at about 12 hours time. So it's really small amount increase after the 12 hours. So it doesn't stimulate the cervix as much anymore. Perfect. Next question, again from Natia. How do you support low-risk inductions? At our unit with outpatient inductions, with ProPES, women can use the birth centre if they go into labour. But if needing further intervention, they are not suitable for birth centre, for labour and birth. So essentially, yeah, after your Dilapan, I think the question is, if they have another intervention, are they still able to use birth centre? What are your guidelines around that at Gateshead?
We're not that posh here.
Yeah, so sadly we don't have a birth centre. We're only a little unit, so we function sort of a whole in one, really. So we don't have a separate birth centre. So our rooms are treated as low risk until we need to change them into a high risk sort of setting. So we don't have that. But yeah, so sorry.
We did.
Yeah,
I don't see any reason why not. They would go to the birth centre, because we've not given them anything, have we?
That's what I was thinking. Yeah, are we saying further intervention as in an ARM, or are they talking about, obviously, if they needed oxytocin, that would be out with the birth centre kind of. So I think
I mean, I guess that's for your unit. I'm speaking out here, not having a birth centre, but I would potentially say if they then even needed just one Prostin gel, I would still be happy with them going down to the birthing centre if they then just have an ARM and labour spontaneously without any syntocin.
Yeah, so I think as soon as you need to introduce oxytocin, that's a different level, isn't it? But I think up until that point, it should probably still be a birth centre. But again, like Jill said, we don't have that. So, and not knowing that this person's set up with their birth centre and is it co-located, I suppose that all makes a difference, doesn't it?
Yeah.
Mm-hmm. I will add that we have several hospitals and sites that sort of utilise Dilapan to open up their birth centre and to try and get more outpatient inductions going. So they sort of open up their inclusion criteria for their outpatients. So I do have awareness of at least one hospital that have now opened up their outpatient inductions to VBACs if they have a Dilapan only, which is really, really nice. So it allows, obviously, we know that the VBAC ladies might have children children at home that they want to sort of spend that time with. So it's really nice. And then if they do go into sort of labour after the Dilapan, then yes, they can move on to a more low risk setting for their labour and birth. So it's all very dependent on the hospital, as Jill and Claire have already said, and what facilities are available. But yes, it's certainly something that a lot of hospitals utilise Dilapan for. Perfect. And then I think somebody did have their hand up originally. I don't know if they're still here. Nope, I can't see them anymore. Any other questions at all that anybody has?
I think there's one new question just come up there. Have we
Oh,
found
yes.
patients who go home with Dilapan return before 12 hours with new concerns? No, we have them return before 12 hours in labour or progressing or, you know, starting to do things. But no, I don't think with any new concerns, Jill. I'm not aware of any that we've had, and certainly none that were in my service evaluation that came back before 12 hours with new concerns. Certainly came back before 12 hours with ruptured membrane spontaneously or in you know, starting to actually do things, but not with any other additional concerns, no.
Yeah, and I would echo that sort of with knowledge of across the UK that hasn't been something that's been fed back to us either. We generally find that women find it a very comfortable induction of labour method, able to mobilise, shower, eat as normal, and that's what's really nice about the Dilapan, is that they feel that they can go on with their induction in a more sort of normal and low risk setting.
Yeah, and that was something that I learned a lot about when reading around with my masters as well, is, you know, when we found that really interesting finding of the length of hospital stay and stuff, and obviously looking more around what other factors could be around that, not just the vaginal discharge and the earlier postnatal discharge. It was around that feeling of, you know, progressing better because they're in their own environment and their own home. And there's so much research around that I think that would be really interesting further study around this as well, because there's a lot of evidence there that, you know, just being in your own home and being in control of your own environment and stuff can then obviously your own natural oxytocin hormones get going. And, you know, there's a lot to be said for that. So there's some real interesting studies that could go alongside the use of Dilapan for that as well.
Yeah, there's an RCT called Home Care, in which they looked at inpatient and outpatient Dilapan, and the findings in that are really fantastic, and definitely fall along what Claire's saying in terms of being in their own environment and decreasing the amount of time of their overall induction there. Lovely, brilliant. Any other questions at all from anybody? Okay, perfect. Well, thank you everybody who has joined. I'll stay on for another sort of 10 minutes or so, just in case anybody does have any individual questions that they'd like to ask. But I'd like to thank everybody for joining and being so open and honest with your questions. And most importantly, thank you to Jill and Claire for your wonderful presentation. We really, really appreciate you sharing your experience and insight, and I'm sure everybody got a lot out of it.
Thank you.
Thank you for watching. We hope you enjoyed this video. If you would like to learn more about Dilapan S and how it can help in your hospital, please visit our website, which is linked in the description.